Hello, everyone, and welcome to Behind the OR, the Peter Surgical Podcast channel, where we invite experts to reveal to us what's happening behind the closed doors of the operating room. Together, we will explore surgeries and procedures and discover more about a surgeon's life in their daily mission. Take off your gloves, take a breath, and let's talk behind the OR.
Welcome to Behind the Operative Room, a series of podcasts in which we talk about the fascinating world of cardiac surgery. I am Bleri CELMETA, a minimally invasive cardiac surgeon working in Galeazzi-Sant'Ambrogio Hospital in Milan, Italy, and I am thrilled to have you join me today. In the previous session, we talked about the beginning of the journey on cardiac surgery. Now, many discoveries in the field of medicine have been just fortuitous accidents. The most famous example, but surely not the only one, was the discovery of penicillin by Fleming in 1929. Well, the next important discovery in the field of cardiology was also an unexpected accident. In 1958, one of the most influential cardiologists of 20th century, Dr. Mason Stones from Cleveland Clinic, was executing an aortic angiography in a 26-year-old patient. Accidentally, the tip of the catheter entered in the origin of the right coronary artery from the aortic root, and the entire amount of the contrast needed for the visualization of the aorta was injected in the right coronary. Well, as a result, the patient had a cardiac arrest and was promptly resuscitated from the medical team. But for the first time in history, though, the right coronary artery was visualized in detail. The team was not discouraged from the episode, but all on the contrary, they repeated this experiment, this time voluntarily searching the origin of the coronary arteries in order to inject a much smaller quantity of contrast. The experiment was a success, and the coronary angiography became and remains still today the gold standard of coronary arteries visualization. In fact, it comes not as a surprise that some years later, precisely in the same hospital, René Favaloro performed the first aortocoronary bypass. This operation remains the most commonly performed cardiac surgery procedure worldwide, representing an annual volume of approximately 200,000 isolated cases. We are slowly completing the puzzle of what finally made possible performing regularly a surgery on the heart. The list of all surgeons of the 20th century, which with their pioneering vision and determination have contributed to cardiac surgery, is very long, and would need an entire podcast series to speak about in detail. But for the sake of time, we will talk about three of them which particularly laid the foundations for today's open heart surgeries. John Lewis, which performed the first successful open heart surgery in hypothermia; John Gibbon, the inventor of the first heart-lung machine, which made possible the first open heart surgery in history; and Clarence Walton Lillehei, which for the first time performed an open heart surgery with a cross-circulation technique. The physiological knowledges of core body hypothermia were becoming always more and more solid. The discovery that the living tissues had less demand for energy and therefore for oxygen when in presence of hypothermia had an important impact on the development of cardiac surgery. In fact, the first successful open heart surgery was performed on September 1952 by John Lewis in Minneapolis, United States of America, using the principle of moderate hypothermia. The patient was a 5-year-old child with an atrial septal defect. She was firstly cooled down until reaching a body temperature of 26 degrees Celsius, with the need of low temperature alcohol flowing on rubber tubes. Afterwards, through a left thoracotomy, the heart was emptied by clamping both superior and inferior vena cava, and the defect was rapidly corrected by direct suturing in some 5 minutes. The publication of this case had undoubtedly a great resonance all around the world, and in the next years, many other patients needing a correction of simple intracardiac defects like ASDs were operated in moderate or deep hypothermic arrest, frequently achieved by immersion of the patient in cold iced water moments before surgery. This technique had, though, an important drawback. Only few minutes of circulatory arrest could be tolerated by the organism. If the arrest lasted slightly longer, the risk of irreversible cerebral ischemia causing invalidating stroke or death was extremely high. It was soon evident that this could not be the ultimate solution for complex cardiac surgery. In our next scenario, let's go back to 2 decades earlier. We're in Massachusetts General Hospital, it's October 1930, and the young lady presents worsening symptoms of pulmonary embolism after a cholecystectomy. At the time, all surgical attempts to remove the thrombi in the pulmonary artery had failed, leading to inevitable death, so surgical embolectomy was reserved to extremely desperate cases. A young assistant surgeon named John Gibbon was in charge of taking care of the patient. When the next day the patient went in cardiac arrest, the surgical equipe immediately performed a thoracotomy, opened the pulmonary artery, and removed the clots, but the patient did not survive. This experience was extremely impactful for Gibbon. He was thinking that with a system which could drain the deoxygenated blood from the veins, oxygenate the blood and reinfuse it to an artery, he could completely bypass the obstruction in the right ventricle pulmonary artery tract, and the patient could still be alive. This idea then evolved in the imagination of a pump which would completely bypass the heart and the lungs and would therefore allow to perform a complete cardiac surgery in an empty heart. He would pass the next 20 years of his life trying to invent perfection and finally implement for the first time on a human being the so-called heart-lung machine. The difficulties to overcome were numerous. He first needed to find the right pump that would precisely inject the needed blood flow to the patient. In the first prototypes, it was a diaphragm pump, while later it was replaced by the roller pump invented by Michael DeBakey, which we still use today. The reservoir was also a fundamental part, in which the returned venous blood was filtered from impurities and air bubbles. In order to control the blood temperature, the entire reservoir was immersed in a bigger recipient containing water, which could be cooled or heated. Last but not least, the most difficult part was the blood oxygenator. The rotating metallic cylinder used for this purpose caused frequently hemolysis and air embolism. Finally, when experiments with the first prototypes of cardiopulmonary bypass started in the 30s, heparin was already discovered and available, but the neutralizing effects of protamine were yet to be discovered. Therefore, great difficulties were posed to find the correct equilibrium between the blood thrombosis, after the contact with the metallic cannulas or glass tubes, and hemorrhage due to excessive heparin use. After more than 20 years of countless experiments on animals with various prototypes of the heart-lung machine, and despite the obvious skepticism in the academic and surgical community, in February 1952, Gibbon performed the first ever cardiac operation in cardiopulmonary bypass on a human being. The details of this historic event, with its groundbreaking consequences, will be the subject of our next appointment for the final episode of the cardiac surgery journey. In the next episode, we will also discuss about the pioneering vision of Dr. Lillehei and the continuous evolution of the cardiac surgery from the traditional approach to the minimally invasive and robotic assisted surgery. Thank you for being with me today and stay tuned for more episodes.